So the first question I posted in the group, 66-year-old man came to the clinic for the routine visit. He has a history of alternated bowel habits. What will you ask the patient? Write 3. Like a lot of you have been asking about bowel habits, blood, and all of those things. So this particular patient, I would like to mention here, his age is 66-year-old, right? So what are you going to rule out in this particular patient would be cancer, okay? So any weight loss, any like any diet problems, or any, like, because alternative bowel habits could be along with the diet, along with any weight loss. So my main focus would be ruling out any cancer like symptoms. Along with, you can do medication, psychiatry, depression, anything like that. But main focus here in 66-year-old particular man would be cancer. Ruling out cancer is very, very important thing. If they ask me to write down 3 things, so one of the most important thing that you shouldn't miss, and next to the 2 you can write anything, but in the one thing that you have to rule out is cancer. So all of those constitutional symptoms, asking about fever, asking about weight loss, those comes first. Then obviously asking about any blood in the stool, all of those things are important as well. But 66 age, they're telling you to rule out cancer, because in Canada a lot of colon cancer history and these things, so you have to rule out cancer. Okay, then moving on to the next one. A 20-year-old man develops fatigue, fever, and sore throat. He has swollen lymph nodes on physical examination. What is the most appropriate treatment? So, like, let's suppose it comes with an option where you have to do is refer to the emergency, admit the patient, start IV fluids, give antibiotics, or do the supportive treatment. So if you have to choose, what will be your answer is? You guys want to write it down, or should I answer the question? Is it okay if I answer the question? Okay, so this is basically 20-year-old man develops a fever, fatigue, sore throat. So all of this is basically showing that he has infectious mononucleosis. So all you have to do is giving that supportive treatment. So this is not lymphoma because he has fever, sore throat, swollen lymph nodes on physical examination, right? So what is the most appropriate treatment? So this particular 20-year-old man, you have to think of infectious mononucleosis first. That is basically supportive treatment. Then if they ask about the differential diagnosis, then the first thing would be lymphoma, or like the other differential diagnosis would be lymphoma. Okay. Then coming to the next one, 84-year-old male came to the clinic to routine visit. He has a history of diabetes and hypertension. It was hypertension. When it is, which is well controlled with the medication, which write 5 questions you will ask in the history. So I'm like focusing on these particular questions about asking, because you have to write down these kind of questions in CDM. A lot of questions may come where you have to write it down about history, and then in the next session I will try to alternate the questions in different way where you have to write it down. So in this one is basically an 84-year-old man. So I have already been focusing in 84-year-old man, which things you cannot miss. So if you guys want to write it down. Yes, so you have to rule out about vision, hearing, gait, urine, and along with this particular patient, medication compliance, or he is taking his medication is very necessary. So first thing first, because they have mentioned about diabetes, hypertension, and he's taking medication. So medication thing is already mentioned in the scenario. So asking about medication would be my first priority. Then vision, hearing, gait, urine, all of fall history, that is also important. So those things comes second. First thing is medication, because in the scenario they have given that he is taking medication. So asking about the compliance of medication. I know he's controlled and everything, but still you have to rule out if he's on regular follow-up, if he's taking the medications on time. So this is very important. Then moving on to the next one would be vision, hearing, gait, urine abnormalities. If they have given you a hint in the scenario, what they want you to focus on, what is actually given, then moving on to the next thing. Okay. So I hope I answered these questions. This is important. So according to the age, you need to rule out these specific things. Now moving on to the family medicine. Okay. So we covered smoking cessation and obesity. So we are going to start from smoking cessation, then comes the alcohol one. So let's just quickly do the alcohol one. So alcohol is basically alcohol use disorder diagnostic criteria along a continuum. So you have to rule out alcohol disorder. If somebody is complaining of alcohol, he is taking it along with the so many psychiatric conditions can contribute to the alcohol use. So eventually you have to rule out psychological aspect along with the alcohol use. So don't forget about the psychological aspect. So more likely to miss a diagnosis in the woman, elderly, and patient with have a high socio-economic status. So then coming to the next one, what is the assessment? How you are going to assess is basically cage question. Cage questions are C, asking about the cut down on your drinking. Have you ever feel like you have to ask that particular patient, do you feel like it is basically asking their insight if they are actually thinking or actually feel like they need to cut it down. Then have the patient or people annoyed you by criticizing your drinking, like you have been drinking too much and your behavior is weird. So people start complaining you and you feel annoyed that they are telling me to cut down the alcohol. So asking about his insight and asking about his environment. Then moving on to ever felt guilty about drinking, because he might have drunk and couldn't attend any particular event or couldn't go to some places where he was supposed to go, so feeling guilty about that. So asking about his own particular preference of that. Then have you ever felt you need a drink first thing in the morning, like eye opening? So CAGE, cut down, annoyed, guilt, and eye opening. So two, yes, then it basically considered as positive. Then there are other questionnaire things too where you have to rule out, but this is kind of important. Where you have to rule out is basically the first thing, which is cage questionnaire. Assessing drinking profile about setting, time, place, occasion. So a lot of things you have to ask on history. It will give you a lot of good compact history where you have to start about the counseling. So asking about these questions: setting, time, place, occasion. If a patient coming to you, 50-year-old coming to you with alcohol, so what are you going to ask from the particular patient? Just like the same question I asked right now, it's just the same. If they put the alcohol history, now you are going to start from the alcohol. Where do you think, where, at what time, occasion, with whom, impact, how many drinks per day? So these are the questions you have to remember, so you can eventually ask them. So setting, time, place, occasion, how many days per week, how many drinks per day, maximum number. If identify positive for the alcohol use disorder, screen for other drug. Because if somebody is drinking alcohol, there might be chances he is taking some other drug as well, like smoking. So if somebody is coming with the alcohol, if they ask me to rule out one more thing, that I would like to rule out is basically ruling out other drug, maybe smoking, maybe cocaine, maybe opioids, something like that. So just to be on the safe side, I want to ask you one question, if you don't mind. That is quite personal. So do you take any other recreational drugs or not? So he will say, no, I don't use it. So it's totally rule out like that. Then coming to the medical psychiatric evaluation. So a lot of psychiatric condition is contributed to the alcohol. Ask about drinking and driving. So it is by kind of violation of the law. So you need to be on the safe side that if we ever drunk and do driving at the same time. Asking about the past recovery attempts and assess current readiness to the change. Then coming to the investigations, what are the investigations you would like to do is GGT and MCV, AST, ALT, and CBC. CBC is basically anemia and thrombocytopenia, INR. So this is basically, if you are going to do the AST and ALT, the alcohol use disorder will show AST 2 times higher than ALT. So if they are giving you specific values and you see AST 2 times higher than the ALT, and they are not giving you any other history, you will eventually come up with that this is patient is using alcohol. So this might be alcohol use disorder. So this is very usually approaches by AST 2 times higher than alcohol. Now coming to the management. So you are going to start with the motivation. This is very important that you are going to do the motivational counseling here, because the patient might be unwilling to quit this alcohol. So you have to start from the motivation, where you are going to build up the form, where you are going to build up the rapport with the patient, and then on the basis of that you are going to start it. Individualized counseling follow up is crucial. So patient motivation for the change is very important, because if the patient is not willing, you cannot do anything, you cannot process further. Then 10% of the patient in the alcohol withdrawal will have seizures and delirium tremens. So you have to talk about all of those things. Then alcohol anonymous program, like 12-step program. Then refer to the specialist for the dangerous or the high stable home environments, medical psychiatry. So you have asked all of these questions in the history. Now on the basis of that, you are going to see which the patient needed. Either he needed 12-step program, either he need to be referred to the specialist because he is getting so agitated, having a problem with his nearby, having depression, maybe that is the problem is causing it. So he needs either to see specialist, either inpatient program, either he need to go to, like he might be abusing, or he might be like doing domestic violence, right? So now he needs to be seen by some specialist. He couldn't go over the 12-step program, or he might need with a family treatment. So according to the all the history, you are going to go and see what he needs further. If his addiction is too much and he couldn't control himself, so he needs to be inpatient. You cannot do outpatient treatment for that particular patient. Then coming to the, and you need to see if that patient is using or abusing, like alcohol use, alcohol abuse, or alcohol use disorder. He has built up that disorder, like using it too much, that is not the safe limit. So alcohol use disorder, you need to know the alcohol normal limit. And you can see it from Canadian guidelines, because they are keep on changing it. Last year they changed to you can take only one drink per week, I guess. On the Canadian task force, you can see it from there. It is like written over there. I will post in the group as well. So I think it is one drink per week, not more than that. So if somebody is using it more than that, it is basically alcohol use disorder. Then coming to the pharmacological, if the patient is having the withdrawal seizures or having those withdrawal problems, so you are going to start with the diazepam. Then disulfiram, it is basically not used or no longer available in Canada. So you can quit, remembering this one. Then coming to the naltrexone is basically opioid antagonist that reduces the craving and pleasure effects of the drinking, may trigger withdrawal in the opioid dependent patients. And then acomprosate, so it reduces the craving. So they both reduces the craving. So there is no preference of one over the other. If the patient is having the opioid problem along with it, so you can use naltrexone along with it, but there is no specific thing that mentioned it that you can use naltrexone over acomprosate. Then coming the prognosis, relapse is common and should not be viewed as a failure. So if the patient is having a relapse, so you should be keep on motivating. It's okay. It happens to a lot of people, so it's totally fine. Do we have to say that I need to ask you a personal question? Is it that a given that we are taking history? No, actually, it's not common in QE1. Like sometimes they want you to write it down that I'm going to ask you a personal question, because these are kind of personal questions. You are asking a history, but that history, if you are going to talk about sexual history, this is not a common history. You are going to break the sentence and say that I'm going to talk about something which is private, and we ask it to particular people or all of the people who come here. So I'm going to ask it to you. So that particular patient knows that what are you going to ask next. So this is basically starting with and building the rapport. This is basically building up a rapport where you are going to talk about the private matters. And before that, you have to give the warning. So this is basically giving a little warning before starting about something private, talking about substance abuse, talking about alcohol, talking about smoking. So talking about sexual history, talking about the occupational, if he is not willing to talk about, like, what do you do as a job? Sometimes people get offended by talking about their salary. Sometimes people get offended by talking about their weight. So you cannot just talk it in the normal history. If somebody is coming with the obesity, right? Now she is already here to talk about the weight. Now you don't have to tell her like I'm going to talk about your weight, right? Because she's already here for the weight. If she is here coming for the sexual history, or asking about STIs, having a discharge and discharge or stuff like that, still you need to tell her like I'm going to ask about your personal private life. So how many partners do you have? You cannot just directly jump to, or do you have, how many partners do you have? This is not nice way. Like, it's just how these Canadian people communicate. So that's why it's important. Then coming to the next one. So it is important in like sometime in QE1, they are trying to see if you have a communication. If you go to that particular chart that is given in the MCC, they have made up like four points of the row and column where there is written acute, chronic, management, and stuff like that. It is very nicely written in the bottom part, communication, where they are going to check your communication even in QE1, not just the NAG. So somebody asked me to explain it, and I'm not sure if I can explain it here. We will definitely conduct a session for that, and I will try to explain how those evaluation of the exam work. So it is very important that you are going to write down what actually is needed, and like just writing down the answer is not enough. You have to know where you are going to write and from where you are going to build that wrapper to. Okay, then coming to the next one, hemorrhagia, allergic rhinitis, concussion. So concussion is one of the very, very important topic. It's not written here in family medicine. So we are going to go to the neurosurgery and emergency. I'm not sure if we can go it in emergency medicine, but let's see in the neurosurgery. So brain injury. So you need to remember these ones. Confusion classification: altered mental status less than 15 minutes, altered mental status more than 15 minutes, any loss of consciousness. So on the basis of that, you are going to grade it. Grade 1, grade 2, grade 3. Less than 15 is grade 1, more than 2 is more than 15, and grade 3 is any consciousness. Then on the basis of this consciousness, right? Now you are going to see what management that needed. So they are divided into 3 grades. So now in this grade 1, what are you going to do for the grade 1? Grade 1 is basically 15 minutes of amnesia. So it says less than 15 minutes. So 15 minutes of amnesia and other symptoms return to the normal. So what you can do is, if symptoms clear within 15 minutes, all you have to do is counsel the patient for 1 day to take a break, don't do anything. And this is just to be on safe side. He doesn't need to take 1 day break, but it is very like high likely to keep that patient to be safe, to keep that patient 1 day break or keep on observing it. If he doesn't want to take 1 day break, at least observe that patient. If it is less than 15 minutes, but at the same time, if the patient is having more than 15 minutes, then it is for sure to remove the activity for 1 day. It is not mentioned that he needs to take 1 day break in less than 15 minutes, but to be on the safe side, it is said that he needs to take break for 1 day. But if he's not taking the break, then he has to be on under observation. Somebody's looking up to him. If he develops any headache or any numbness or any weakness or something like that, he needs to come back. Now moving on to the grade 2, where he already has altered mental status for more than 15. Now taking the break for 1 day is compulsory. Remove from the activity for 1 day, then re-examine. Then you are going to re-examine if he has any headache, any vomiting, any nausea, or anything like any numbness or any weakness, any part of the body that will show that he has developed some sort of brain issue. Then on the basis of that, you are going to examine CT or MRI, sorry, if headache or other symptoms worsen or we are lost more than 1 week. So if he's having a headache for more than 1 week, that's the problem. If he's having a nausea, feeling of that, and then numbness in one hand for more than 1 week after falling down, so this is a problem. Now he has to do CT or MRI. Return to the normal activity after 1 week without symptoms. So if he develops this, okay, let's suppose he's coming to you more than 15 days, what 15 minutes with the altered mental status, what are you going to tell first? He needs to stop doing activity for 1 day. Then moving on to the next one, you have to keep on observing and then see if that particular patient develop these symptoms or resolve these symptoms within a week. The week is the set limit. If he develops these symptoms, then you are going to move on to CT or MRI to see if there is any hematoma or any hemorrhage within the brain. So if he needs that more than 1 week, the symptoms is not resolved, so you are going to do CT scan or MRI. If those symptoms resolve within 1 week, so he can go back to the activity, start doing whatever he wants. But it is not going to restart like he was playing basketball, he's going to restart the basketball right away. No, he needs to develop it one by one. First day he's going to start walking, second day he's going to get little like play area, then moving on to the next step where he's going to do the same activity. Then on the second step, you are going like slowly he's going to start the activity again. So this is very important, where you are going to counsel the patient. You have to start this again and again and again and again, how he's going to keep on regaining his all the activity. So it's going to take the whole 1 week. Okay, then coming to the any loss of consciousness. Now this is dangerous. So it is basically emergency neurological exam imaging. If the initial exam is normal and may go home with a close follow-up. If the patient loses consciousness, he suddenly regain it, you did the examination, he came to emergency, everything is normal, all you're going to do is either ask the patient to stay here if there is nobody to take care of that patient at home, or he can go home and somebody will take care of him if he develops any of the symptom to come back to the emergency right away. So if admit if any signs of pathology or persistent abnormal mental status, CT or MRI if headache or other symptoms if brief loss of consciousness less than 1 minute, return to the normal activity after 1 week without symptom. So this is what they're talking about. If the brief loss of consciousness, so 1 week is the set time. If it's totally okay, so you don't need to do anything. But if it develops something, then you are going to switch on to CT and MRI to see if this the problem is going on. If prolonged loss of consciousness more than 1 minute, return to the normal activity, often 2 weeks. So this is the set limit. If the loss of consciousness was less than 1 minute, then the activity can be regained at 1 week. But if the loss of consciousness is more than 1 week, sorry, more than 1 minute, then the activity should be regained in 2 weeks. So this is very important that you remember these things. How many regain of consciousness minute is going to be affected the regain of the activity. So these are very important. Less than 1 minute, he can regain the activity in 1 week. But if more than 1 minute, then he is going to regain the activity in 2 weeks. So this is very, very important, these numbers. When are you going to counsel the patient to start his activity again? Then coming to the brain activity, mechanism of injury determines the pathology, like penetrating. So how does it happen? Like low velocity, high velocity, contusion, coup, contusion, and deep axonal injury. Sometimes some people just mix up this contusion with contusion. So contusion is something like having a like little hit on your head and got a little hematoma, a trauma induced alteration in the mental status. That's why he got little confusion, fall down, having mental status, having loss of consciousness for a second, or having this like mental status disturbance. So this is basically all with the contusion. Now coming to the contusion. Contusion is basically having hemorrhage, epidural hematoma, subdural hematoma. So that comes with the contusion. So it is high density areas on CT or a mass effect, and commonly in the brain impact on the bony prominence, like inferior frontal lobe, pole of the temporal lobe. So you have to remember bit of the which one is which artery is more common when hematoma happens in the temporal lobe. Sometimes it's kind of important and sometimes it's not. So just to be on safe side, just look at it which are more common arteries to be on that particular area is gotten damaged. Okay. Then coming to the coup is encounter coup. So already we know that if the sudden blow and the same area is affected, this is basically coup. And then opposite area, if that, collapse back. So basically counter coup. So this is coup if somebody got hit from here, and counter coup is when brain got hit by here and then came back. So this is basically counter coup. Then diffuse axonal injury. How it will present is basically started developing loss of consciousness if no space occupying lesion on CT scan you didn't find anything, but the patient is having numbness, weakness, it's hard for him to get up out of the bed, having headache and all of these features. So this is basically diffuse axonal injury. Then coming to the these are extracranial conditions, hypoxemia, hypercarbia, hyperpyrexia. So you can see all of these conditions are related to some particular underlying pathology that is going on that is further causing this kind of conditions. Then intracranial. So this is something with the neurosurgery. That what important was brain injury that we already discussed. These are important. Then coming to the CT and MRI. Let's just quickly see the CT head of the rule. So this is for the patient for the minor injury. So coming to the major injuries and the moderate injuries, you are going to do the like coming to the minor injuries in which there is particular patient you are going to do CT scan, but in the high risk or medium patient you are definitely going to do CT scan. Now minor is further divided into three, like how I am making this like further. First, head injury is divided into three: high, medium, and minor. Now high and medium you are definitely going to do CT scan. Now the minor one is further divided into three, which is basically high risk, medium risk, and minor head injury. Now what is minor head injury is defined as a witness loss of consciousness, definitive amnesia, or witness disorientation, where we said how we are going to do CT scan and MRI. So that was they are talking about here. So if that patient has a definitive amnesia or a witness disorientation with a GCS score of 13 to 15 or less than that, is basically now coming to in the criteria of minor. If that patient is having GCS less than 13, so that is coming in the medium risk, and then if it is less than 8, then it is basically coming into the high risk. Now coming to the minor, which was further divided into three, like high, medium, and minor. So high, in those particular patient where the minor head injury, which one is included in the high risk? High risk is those ones where GCS is less than 15 at 2 hours after injury, suspected open and depressed skull fracture, any basal cell fracture like having hematomponum, raccoon eyes, cerebrospinal fluidotoria, or battle sign, vomiting more than 2 episodes, and age more than 65. So let's suppose if a patient is having a minor head injury and his GCS is 14 and his age is 65, right? So do I need to do CT scan or not? What do you think? So we are going to do CT scan or not in this particular patient. So definitely, because his GCS either is 15 or either less than 15, his one criteria is fitting in the high risk. So I am going to go with the CT scan, because this is either minor head injury, but he's fitting in the high risk one. So he needs to do CT scan head. Okay. Then coming to the medium. Medium is basically amnesia after impact more than 30 minutes. Dangerous mechanism like blown out of the vehicle, or fall from the height of more than 3 feet, or an motor vehicle injury where he was ejected out. So these are all medium risk. In this condition, you are going to do CT scan. Minor head injury is defined as the witness loss of consciousness. So in particularly, if we are going to make a chart, if I have to make a chart, let's suppose I make a chart. Where is this? If I make a chart, okay. So if I have to make a chart, first the head CT head, where I'm going to see, like the head injury. So this is basically head injury. Then coming to the high risk, sorry, that is high risk. Then coming to the medium, then coming to the minor. So this is minor. So if I have to do, so this is these and this, medium and high risk, I am definitely going to go CT scan. Okay. Now minor is further divided into three, which is basically high risk, medium risk, and minor risk. So high risk, I am going to see which is the criteria. This one is the criteria. Then coming to the medium risk, I am going to see the criteria. Which one is the criteria? This one is the criteria. Okay. Then on the basis of that, we are going to see if I'm going to do the CT scan or not. So on the basis of that, we are going to do the CT scan. So it's very important if you know where you are going to do the CT scan and where you don't need to do the CT scan. Okay. So this whole table is very important, and sometimes a lot of questions or MCQs can come from it. So your concept should be very, very important. That's why I took so much time to make you understand where you need to do CT scan. And it is okay to write down where you have to write down no CT scan is needed. Okay. There is a lot of questions where you have to write down no, or no investigation is needed. So it is totally okay to write it down. Okay. So don't just confuse that. Why should I do write down CT scan? This person has a head injury, I should go with the CT scan. So this is not like, it doesn't work like that way. Okay. So this is how this CT scan works. There is an MRI. I think that is written in emergency. So when we will do emergency, I will show you how to remember the MRI one. Okay. So that's it for today. If you guys have any question from this one, it is kind of very, very important. So make sure you have good concept about it.